a seat.
Thank you.
Well, those are terrific presentations. I'd like to ask all the presenters if they'll come on up and have a seat, and we can start our discussion period.
Mm-hmm.
Yeah, I'll stand here. You know, I thought I might start off with a question for Dr. Shroff, but also for the entire group. You know, we can understand why stenting a lesion that is not significant resulted in poorer outcomes, as you suggested. It was kind of periprocedural problems and then restenosis. Dr. Karapanos talked a little bit about why bypassing a graft with that results in competitive flow can result in poorer distal outcomes, essentially through I suppose, a mammary artery steal phenomenon from the coronary arteries. Do you think that this is probably the important reason why we shouldn't be grafting non-physiologic lesions? Or is there another thing that we should be doing? Is how do we put it all together, is what I'm asking. How do we put together FFR and competitive flow and determine what we should do in the operating room?
I mean, I'm not in the operating room, but I agree that...
That's why I asked you first.
Yeah, absolutely. You know, I think that it's a great question. I'm stuck with what are the options. A lot of times we'll see these arteries, and I think the message that I get, I guess I try to focus on things that I can control, and I can control the cath lab and what I do and my community does in the cath lab. And I think that, you know, if the LAD or the left main is not critically tight, if you're not certain that it's over 70%, you should FFR, you should I-visit, that should be part of our routine practice, because I think that's all I can do to help you have good outcomes. I do get nervous about this, but from my review of the literature, I don't know what the option is, because it does seem like there's probably a lot of, we're seeing a very small percentage of the people that come back who have non-critical lesions, but there's probably a lot of people who have non-critical lesions whose lemas don't go down. We just don't see those people, right? We don't focus on those people. So we don't really know what the denominator is. And I think that's why we need a protocol angio group where we take 100 people who have CABG and they all get redos, get protocol angiograms and see that question. So.
Yeah, I mean, and that I think, you know, brought up the great question. We focused a lot on graft patency, but is that the wrong thing to look at? I mean, it's really a surrogate endpoint because we really want to know is how the patient does clinically. And, you know, although maybe there's an acute problem with a decrease in distal flow, maybe that graft will close and the patient will be fine. But the difficult question I wanted to ask you, Nikolaos, is when we see the pattern that suggests there's a lot of competitive flow, should we proximally occlude that coronary artery?
Well, is it open, this one?
Can we have the other microphone on, please?
Is on? Okay.
Yes.
Well, Dr. Sabik, thank you. I didn't expect that you're going to ask such a difficult question now, but so I really appreciate it.
Howie told me I could.
Howie told you that? Oh, my God. Well, now, the reason that I conducted this study is that I had the same question when I was practicing clinically. So I wanted to see what actually is going on with the flow that we came here for today, all of us in the OR. We came here to give blood distally of the anastomosis. So this was the question. That's why we conducted this study. Honestly, I think that no one else in this room and no one else of the attendees of the 2013 AATS Symposium knows the answer. What I know after the conduction of this study is that we need further studies properly designed in order to give us the answer of this amazing question. The straightforward answer would be yes. You have your anastomosis, you have your lesion, you perform a perfect anastomosis, just distally of your lesion. So then, yes, why not to ligate proximally? Well, this is a scenario that you can see in the lab for good or for bad. It's not the same thing in the clinical reality because there is a retrograde flow, and as Teresa showed us before, this retrograde flow in the native coronary artery may be very important for the health and the life of the patient. So in that case, it would be catastrophic to ligate just before the Lima to LAD anastomosis. So I'm sorry that I cannot give you an answer. No one can. We do not know.
Is there a question from the audience? Yes, sir.
Transfer to clinical practice. When we have a patient that has acute infarction, and they do PCA, but in the PCA they found a left main, Dr. Sabik. What do you do when you operate the left main with the right coronary artery that has been put a stent?
So the
patient has an acute myocardial infarction. The clinical cardiologist made a stent in the right coronary artery. In the study, he found a left main and multiple lesions in the left side. And he said, go to the surgery for the left main and the other, the left coronary artery. What do we do with the right that has already a stent? Do we put a graft or no?
No, I think that's a great question. There are several components to that question. The first one is how to manage the anticoagulation protocol of that patient, because it's very likely they're on Plavix and the cardiologist does not want you to stop that. And then the second thing is, do you restudy them and when do you operate on them? You know, I think if it's somebody who is stable after the stenting, I usually do like to wait a little while, and the cardiologist likes us to wait a little while. And our practice has been to wait about 4 to 6 weeks, if we can. At that time, we do stop the Plavix and admit them and put them on Integralin, and Dr. Shroff will tell me there's no data to support that, but that's what we do. And then my approach has been to graft that right coronary, and I do put a vein graft on it. You know, as we heard today, the vein grafts aren't really susceptible to competitive flow. And my feeling is I always tell the patient, I'm going to let God decide whether that vein graft stays open or not. But we've all seen, and I've seen this post-operatively, where we haven't grafted those situations, and those stents have acutely thrombosed, and that's usually a very bad outcome. So I tend to be on the conservative side. But we've got other surgeons here. What do you all do? Teresa?
That is I mean, I've been on that side where you've not grafted and you take them back like half an hour later. I think it depends on many things: the age of the patient, the lesion that was stented. If it's a very good result and you can afford to wait, I usually don't bypass it.
Even at 6 weeks?
Yeah, if it's you know, I know that compared to flow, it's just in the vein graft. I mean, if the person's older, yes, but if the person's younger, I would prefer to, you can even re-angio them and do a CT angio to see if it's open, but I would just do 2 mammaries. And if the worst case scenario, he goes down to a single vessel disease, if that stent goes open. The stents are pretty good, the drug-eluting stents, so that's what I would do.
Yeah, I'm always a little bit worried about how we alter their anticoagulation protocol perioperatively. You know, we give them protamine, they're not on heparin for a period of time, they're off Plavix, and I'm always a little worried. We will start Plavix afterwards. We often even start at the night of surgery, but there's a period of time where their platelets
Are you
rehab.
talking about drug-eluting stent or bare metal?
I was mostly referring to drug-eluting stents.
Okay, yeah. Our cardiologists often will put a bare metal in purposely for this, so we don't have to worry about that.
Dr.
Very rarely I graft distal to open stent. Very rarely. At least I discuss it very carefully with the cardiologist. But what I think is important and an important message is to learn or teach at least our juniors, and also teach those who are not used to flow measurements to utilize the equipment as good as possible. And you have to think about all the variables, as we have seen, but also you can also simulate an active and a resting state of the patient. So what I do, and we do flow measurement in all our coronary cases, everybody, whether we do 1 or 5 grafts, we measure everything in every case. So by that you get more knowledge, you get more feeling about what to expect in your next case, and in another complicated case or easy case, whatever. So what we do is for this, I do now more and more, because the more experienced I am, the more I do measure flow. I learn more. So before it, if I do, usually we do the on-pump method, off-pump occasionally. But before I remove the clamp of the ascending aorta, I do a flow measurement on the lima, as there is no competitive flow. So that gives you an impression whether, at least you can tell whether the lima is, the graft, the anastomosis is open. You cannot tell whether it's a 50 or 70% stenosis, but you do get an impression. And then you would usually find some 50 to 100 mils going through. Then I do finalize everything, also proximal, go bypass, and then I have a physiological state. And I measure the baseline and also do a papaverine injection into the grafts, the vein grafts, rarely into the lima or arterial grafts, but sometimes if you are in dope, you can do that. Diluted papaverine. Then you will see the flow reserve, which means you can better assess the benefit patient will have through the grafts.
Nikolaos?
Well, I think I wouldn't do anything different from what Teresa is doing. I would just comment on maybe a very interesting measurement that we can also have, while in on-pump cases, have a measurement with full flow before reversal to see what's the response of the vascular bed under full flow with the pump, and then do whatever you do. So maybe this would differentiate things a little more better. But clinically, I would do what you do.
You guys are all braver than I am. Yes, sir.
What exactly is the role of competitive flow in sequential grafts? It's
Here you
different if there is competitive flow side-to-side anastomosis compared to the distal end-to-side anastomosis. I think there is.
Teresa, you want to handle that one?
There's David Gleaner has written a really good article on competitive flow, 2012 Current Opinions in Cardiology, and he really stresses that composite and sequential grafts really are affected. He recommends that you only put them on very high stenotic arteries. But I've been measuring sequential grafts now for about 10 years, and I've got a whole slew of these sequential and composite grafts, and it's very interesting. Usually, for a sequential graft, you can measure the whole thing in the mid-segment, and usually the mid-segment is half or so the other one, but occasionally you'll have, especially if your diagonal has a stenosis of, say, 70% and your LEDA has 100%, you've got an increase in the mid-segment, because what's happening is the diagonal is actually helping the LAD. And I have a couple of patients who the proximal part has gone down, and this is a really long time ago, well, about 9-10 years ago, and I was starting all my arterial grafting, and the cardiologist would angioplasty the native vessel, and they'd see the mid-segment lighting up, so that by angioplasting the one vessel, he actually got two. So, it depends on your severity of your stenosis. I think it's probably better to put sequential grafts on high stenotic vessels. But having said that, no patient is perfect. They don't present themselves that way.
Is there any difference compared to the distal end-to-side and the more proximal side-to-side? Is it more negative for your papacy if you
Yes.
have your distal end-to-side anastomosis on a competitive vessel than on a totally occluded vessel? And more important, is there a difference between the left-sided
Yes,
system
and the right.
the right side?
I don't know. I would love to look at all my sequential grafts. Maybe if you could answer this.
Yeah, I think, standard teaching would be you put the sequential graft, you end your sequential graft where you believe your best flow would be. So with your most stenotic or highly, totally occluded vessel. But I think the point that Teresa brings off is very good. If somewhere along the route of your sequential graft, there is an artery that doesn't have a significant obstruction, you may end up with just a coronary bypass.
That's right. That's
And I think we've all seen that on cath films.
Place your distal arterial graft on a 50% RDP and stenosis when you have an MO2, which is completely occluded.
Well, you might end up with the coronary where the proximal part closes and your distal is feeding your circumflex branch.
Are you getting practical, or are you just placing a venous graft on the
I think Teresa's point is well taken. If you're going to do sequential grafts, you should most likely do them to vessels you believe that are very stenotic and have significant lesions. Otherwise, you'll end up with a coronary bypass.
There was, we actually wrote a paper back to 1986 or so, Gerald M. Fitzgibbon, the ABO classification on sequential grafts, but this was veins. And what we found was that the side to side stayed open in preferential to the end to side. So you were losing, and Fitzgibbon, his premise was you're losing the most important vessel in your heart, the LAD, for a diagonal. So that's for veins, though. That's not for arteries. And, so if you do have a coronary bypass, well, that's better than nothing,
Yes, sir.
Curious what the panel would do with a patient who has a 60% LAD, doing triple vessel disease, you've done all the other vessels, and you now have a 60% LAD with a 0.82 FFR. Would you consider using a vein graft in that setting? And then the second part is, pretend you've already done the LAD, the lima to the LAD, and you find severe competitive flow. You go back and put a vein graft on that patient?
I don't. The lima and the rima are least susceptible to competitive flow. And that's one in Gleaner's article. He states that the radial artery, definitely, you do that. But I have, I'm collecting data for a paper that I'm going to call Against the Rule. Because I have put, we all have done this, put mammary arteries on 50% LAD lesions, 50% left main, isolated left main, and they stay open. I have one patient who now has a 40% left main, and there's two beautiful conduits, the natural coronary artery and the lima, and there's no string sign. So I don't think you can never say never. I think these are guides, and I think the LAD deserves a lima.
Yeah, I'd like to answer that. Even, and we saw some beautiful FFR data, which is similar in some of those graphs or some of the work that myself and Dr. Blackstone did, and we were, at least when I was growing up in heart surgery, I was taught that you got to 70% and then IMA patency went down, right? You had a steep cutoff, and a lot of the work that we did showed that it was very gradual. And if you even add a 60%, if you take an IMA and you put it to an LAD that's 100% occluded, your patency is nearly 100%. When we see these 93, 92%, that's for the spectrum of proximal stenosis. But when you get down to about 60, you still have a 90% 10-year patency of that mammary artery. All right, 1 in 10 are going to fail, but 9 in 10 are still going to be open. If you then compare that to a vein graft, right, by 10 years, the magnitude of that difference is huge. Only about half of the vein grafts are open, and still 90% of your IMA grafts are open. So I do believe it's the wrong move to put a vein to it. The IMA is not perfect, but it's still very, very good.
Even with the high FFR?
Well, 0.82, and again, that was my comment about linearity. I know we all like to dichotomize things, whether it's 0.75 or 0.8, but again, one of the questions I was going to ask is, how did we come up with that number? Where did that number come from? Did a bunch of people just do these tests and then see if people developed ischemia, or did they stress them? Because it's really a cutoff, so it's really continuity. And just like the patency doesn't all of a sudden fall off, it's a gradual decline. So there is some increase probably in competitive flow going from 0.75 to 0.82, but is there really that much difference between 0.8 and 0.82? Probably not, right? Is there a difference in an outcome between a 70 and a 71-year-old? Probably not, but we think that, over 70 is bad. Well, maybe 0.82 is not as good as 0.8, but it's probably not that much worse.
You draw the line at 0.9 then, or?
Yeah, no.
Yeah, we get into this deal all the time, at least in the cardiology world. And I think exactly this question of 0.7, 0.8, 0.75, and 0.8. And initially, there was a correlation in the initial trials with stress tests and with recurrent events. And this is where the sort of the lines sort of converged at right around that 0.75 to 0.8 is right where the risks and benefits converge, and that's how they picked that number. It wasn't, thankfully, it wasn't just an arbitrary number that they just picked out of a hat. And then the 0.8 was just because in the initial paper, that 0.7 to 0.8, there was this question of, it was almost like a coin toss. And so that left a lot of us in the cardiology community very stressed when we see these patients. We didn't know what to do with them. So it's sort of like how you're mentioning is, you know, because these are all tracked, and we get appropriateness criteria report cards now. And if we are stenting people, which I think is, to your point, is there really much of a difference between a 0.81 and a 0.79? No. I mean, those are the same people with the same disease. And you just give a little more adenosine, give a little more drug, move your guide catheter around a little bit, and you can get to the number. But there are people who count those things. But I think physiologically, I agree with you that it doesn't really, they're probably the same patient and the same outcome. And I don't, you know, so we struggle with the same thing.
Yes, sir.
Hi, Philip Hayward from Melbourne. Dr. Sabik, we crossed swords about this at San Francisco last year. But I just want to reiterate the point about the FFR and the competitive flow. And I just want to jump the idea that competitive flow doesn't exist in vein grafts. In the paper that Dr. Shroff quoted in the surgical series, there is a definite and significant drop-off in vein graft patency when veins grafted to lesions with an FFR greater than 12 days. And in our series from Melbourne that we presented last year, the vein graft patency for moderate lesions is only 40%. And what you might say, well, as you were just saying, well, okay, so 60% of the grafts fail, so what? But if there's no real lesion, does it really matter? But it does, because the vein grafts seem to confer a definite acceleration in vein vessel disease. And so a vein graft to a non-significant lesion is a bad thing. Vein graft has a high chance of failing, and it will accelerate major vessel disease. And so I'm afraid, I respectfully disagree with Dr. Sabik. We've got a vein graft through a stented by coronary dialysis.
Well taken. I still think you're wrong. We have about 10,000 grafts, and these are analyzed over about 30 years. And many of them back in the, I suppose, as Dr. Lytle would always say, the battle days, they were grafting 40 and 50% lesions, and we saw no difference in patency at all.
We can't match that. Australia is a young country.
Any other questions? Yes, sir.
For the open CABG surgeon, it is not a big deal to revise the anastomosis based on the bad flow or bad PI. But Dr. Sabik, I believe you do on-pump CABG with cardioplegic arrest, right? So what's do you measure the flow?
Yeah.
If so, what's the criteria to revise the anastomosis? What kind of flow and PI?
Well, you know what? Whenever that happens to me, I'll let you know. But you know, actually, this is something we've been talking about with Howie, and I'm actually going to defer this question to Teresa because, as we all, you know, Teresa has kept incredible track of her grafts. And one of the things that Howie and I talk a lot about is how often does this happen, and then how often does a revision make a difference? Because I think that's the bigger question. Because sometimes we get bad numbers because of competitive flow or severe diffuse distal disease. So I'm not going to take a crack at it, but I'm going to ask Teresa to take a crack at it.
Thanks, Joel. I'll do my best. I think, yes, I do both off and on pump, and I did mostly on pump. I only did 6% off pump up until 2008. The trick is to measure every step of the way so that, for example, just like you, Rune, you measure with the cross clamp on. With the cross clamp on, the lima flow, it's like 70, 80. It's a straight line because there's no pulsatility, and your PI is 0.8. You know at that point your distal is fine. So then you take the cross clamp off, and you've got a good graft. When you come off pump, if there's a problem, it's usually the conduit. So you measure every step of the way so that you don't, if you only measure after protamine and you find out that it's a bad graft, you've got to go back on pump, cross clamp, da-da-da-da-da. No fun. So if you measure every step of the way, you can catch it before you do the final step. You know, and for graft redoing, I probably redo less than 1% on pump and probably 4 to 5% off pump. That's, you know, it's just the way it is.
What do you usually find is, so let's say we're talking about 4%.
Yeah.
what do you usually find is wrong with that graft? And how often can you convert that 4% to perfect?
Okay, that's a very good question. Okay, I would say more than half of about half of the time it's something so simple. It's like a subtle twist of the heel. Or, if you bring your lima through a hole in the pericardium, there's a cut edge of the pericardium is impinging on that mammary a little bit. You make the cut a little bit bigger. And when you redo the graft, sometimes you find absolutely nothing wrong with the distal. You find, I even have a note that I brought with me because I wanted to review the operative notes on those 7 patients. And I'm reading this and I'm going, jeepers, there was nothing wrong. I even said in the note, I took down the anastomosis, I could find nothing wrong, but when I had redone it, the flow was much better and the patient was happy and they never came back. So you don't find sometimes a reason. I don't know what it is. Whether there's an intimal flap or something that develops that you don't see, or you caught something. The other thing that I really stress is if you make a change to the bypass, you remeasure. If you put 1 extra stitch at the heel, that's the case that I presented at EX, there was no retrograde flow and the patient, I had to bring them back the next day because the one graft had, it wasn't that patient, it was another patient, but it had compromised the retrograde flow. And I took the patient back. I redid the LETA because of that 1 stitch at the heel had compromised that retrograde flow. I redid the LETA and I put a vein on, okay? You'd be very proud of me, Joe. I put a vein on that one in the back. And he was cathed 4 months later because his thallium was positive. He had no symptoms. And I'm going, Jesus, Mary and Joseph, now what? So, and you know what we found? The vein had become a string sign. The LETA was filling the whole of the heart. And I'm going, has anyone ever seen a string sign on a vein? I haven't seen. And one question I have for people is, what happens to string signs of mammaries? Do they reverse? Because we know that sometimes a radial string sign can reverse. Didn't they find that from Acker's group?
I think there's been anecdotal evidence of both IMAs and radial arteries reversing.
But we don't know, do we?
No.
No. I wish they reversed. Anyway, that's...
Thank you. Any other questions? Yes, sir.
In the setting of an acute infarct, when one's forced to bypass, your runoff, does that affect your flow measurements at all? If you have a borderline sort of reading of PI around 6, flows around 10 to 12, or is that just indicative of edema and bad runoff? You have to go back and review anything?
Shall I answer?
Go ahead, whoever would like to take that one. I don't have experience with that, so I don't know.
Yeah, I would really test for competitive flow on that patient, and if you could demonstrate that there was a rise in flow and a drop in PI, with that you're probably okay, but those patients, acute infarct, should all go on Plavix post-op. There's a higher incidence of graft closure in acute infarcts, acute STEMIs, and we routinely use Plavix. Plavix is a fabulous drug, really, post-op. I love it.
You have to wonder if there's some thrombus in your distal runoff as well, if it's been totally occluded. All right, great. Well, I want to thank the panelists for great presentations and great discussion, and thank the audience as well for being active participants. Thank you, and thank Medistem for sponsoring. I had the easy job.
No, I don't think so. You better